Okay, welcome to the IMS Conference 2024. I am delighted to be the chairman of this symposium. The symposium is called Vaginal Atrophy and Lichen Sclerosus, Clinical Best Practice for New Therapies. My name is Eduardo Serrano. I am the scientific officer with StrataPharma, which is the manufacturer of this device that we are presenting the clinical data today. StrataPharma is a Swiss medical device manufacturer specializing in wound care, dermatology, oncology, supportive care, and with the latest addition that we're showcasing today in gynecology and women's health. Myself, I am a trained pharmacist and biotechnologist. I've been in the medical industry for more than 15 years. Started my career in oncology drug discovery, and then I moved into in vitro diagnostics. And for the last 12 years, I've been leading the science department at StrataPharma, and nowadays I oversee the clinical operations and the new product development with the company. Today, the goal, the purpose is to present the early clinical data with StrataMGT. And we have a wonderful team of speakers with me today. And the plan is to show you the results that we've been gathering over the last 2 years. So with me, I will be introducing the team one by one. But it's going to be 4 presentations, 15 minutes each. And at the end, if we have some time, we will allow for some questions that we will take as a group, or if they're individual, we will take them individually. So that's for the general introduction. So the first speaker today is going to be Dr. Andrew Goldstein. He graduated from University of Virginia School of Medicine, and soon after he joined the faculty of the Johns Hopkins School of Medicine. Since 2002, he became the director of the Centers for Vulvovaginal Disorders in Washington and New York City. He's currently a clinical professor at the George Washington University School of Medicine. He's also the founder and president of the Gynecologic Cancer Research Foundation, and he's published more than 100 peer-reviewed articles on female sexual dysfunction, sexual pain disorders, lichen sclerosus, lichen simplex chronicus, vulvodynia, and vestibulodynia. He has a strong commitment to global medicine, and since 2015, he's also doing voluntary work in South America and Southeast Asia. More recently in Cambodia, volunteering along with his wife, who's also a dermatologist, who's a dermatologist, and 11 different NGOs providing medical care, more recently in the early diagnosis of papillomavirus in low-income, high-risk populations. So that's introduction. Thank you, Dr. Goldstein. The room is yours. Thanks.
Thank you very much for having me here. I get to talk about my passion, a disease called lichen sclerosus. I do want to let you know that these slides are more comprehensive than the 15 minutes that I have to speak. So, but the information on there is for completeness sake. If you take a photo of this QR code, or I will also show this QR code at the end, you can download this presentation. So lichen sclerosus, spelled with a U, not an I, is chronic inflammatory skin disease that predominantly affects the anogenital skin and mucosa. I'm sure most of you are familiar with this disease. The symptoms of lichen sclerosus, mainly in the menopausal woman, is pruritus, irritation, burning, and rawness. In reproductive age women, the most common presenting symptom are sexual dysfunction, including dyspareunia and anorgasmia. The symptoms that women will experience are they'll complain of scarring or occur textural changes, tearing, fissuring. They'll have dysuria, although up to about 58% of women can be asymptomatic, but that's mainly in reproductive age women. The signs of lichen sclerosus, you have hypopigmentation, lichenification, erosions, fissures, ulcers, petechiae, ecchymoses, and of course scarring and architectural changes. The scarring and architectural changes, you'll have resorption or loss of labia minora. You'll have phimosis or covering of the glans clitoris by the prepuce. You'll have narrowing of the introitus, both anteriorly and posteriorly, causing tearing and can cause urinary dysfunction as well. Now, the prevalence of this disease, the most cited prevalence in the literature is 1 to 300 to 1 in 1,000. But if you actually dig down and go back to what that came from, that was just based on an opinion of one expert in 1971. And that citation has been cited hundreds of times. Often it doesn't go back to the original citation. But if you actually dig deep, there's actually there's nothing really there. So that was just one person's expert opinion. Most people who treat this disease, or experts now, think this is much more prevalent. A study that I did in a general gynecology practice now in the U.S., women have access to gynecologists not as specialists, but as their primary care provider. So it was about 1.7% of women in a general gynecology practice. Up to 3.3% in women in nursing homes, and higher in women with Turner syndrome. There is also reported in the literature that there's a bimetal peak incidence in premarital girls and menopausal age women. That may be a complete detection bias, because when women or girls have no estrogen, they're much more pruritic. And so they'll come to their doctors and they'll be complaining of itching and burning and pain. Whereas in reproductive age women, often they're asymptomatic unless they have enough scarring to cause dyspareunia. So we actually believe, and have done recent studies, that actually this is probably not this bimetal peak incidence that females of any age as well as males can have lichen sclerosus, but that they're more likely to be diagnosed when they're hypoestrogen, have a hypoestrogen state. I can't go into the complete etiology of this disease. I could spend an entire hour talking about this, but this is basically, there's a monoclonal T lymphocytes in the basement membrane with circulating autoimmune antibodies, and so this is abnormal activation of the Th1 autoimmune response. We did do a study a couple of years ago where we did a punch biopsy of normal vulvar skin and then a biopsy of adjacent sclerotic skin, and we isolated the microRNAs from this tissue and used this to compare gene expression. And I don't want to, again, go into each individual genes that were upregulated and downregulated. And again, this is way too complex to go into right now, but basically, again, this is a loss of self-tolerance leading to autoimmune antibodies to ECM1, which is extracellular matrix protein 1, that causes inflammation, and this inflammation leads to the chronic scarring that you get. It also can lead to abnormal self-growth and the initiation of squamous cell carcinoma. 4 to 7% of women with not well-treated lichen sclerosus will develop vulvar squamous cell carcinoma. The diagnosis of lichen sclerosus is made, can be either clinically or with a punch biopsy. A punch biopsy should be initiated before treatment because if you treat with high-potency corticosteroids, the pathognomonic changes of the histology can change so that you lose that ability to have the pathognomonic changes. The classic histology is that you have hyperkeratosis of the epidermis, you have epidermal atrophy with loss of reedy ridges. Then you have this huge layer of homogenization of collagen beneath the epidermal junction. And that's why the skin looks so weird, and why it looks white and thick and waxy in appearance. And then all the way at the basement membrane, you get a lichenoid T lymphocell infiltrate. This is important. So if we look down here, you see all of these lymphocytes. And this is important. I'm showing you this because I'm going to show you some data using StrataMGT and how this disappears with the use of this product. Early lichen sclerosus often just shows chronic inflammation, and it does not have these classic pathognomonic histologic changes. So don't be confused by a negative biopsy saying, okay, these women don't have lichen sclerosus. Again, it's sort of late stage disease have these classic changes. The current treatment approach, and almost all guidelines recommend the ultrapotent corticosteroids. Usually, most guidelines suggest daily for 1 to 3 months, then every other day for 1 to 3 months, and then twice weekly for 1 month, and then reassess. Most authors do recommend continuing 1 to 2 times per week, either using the ultrapotent corticosteroids or stepping down to a less potent corticosteroid. Recent studies suggest that maybe mometasone, a less potent corticosteroid, may be as effective as clobetasol. There are many experimental treatments, however. Calcineurin inhibitors have been shown to be effective for the treatment of lichen sclerosus, though less so as compared to the ultrapotent corticosteroids. So a controlled trial that I did looking at pimecrolimus versus clobetasol showed that they both had efficacy, though clobetasol was statistically more efficacious. There is the phase 2b study of a JAK inhibitor, ruxolitinib, is coming out, and I can spill the beans a little bit, and I bet 5 years from now we'll be using JAK inhibitors instead of corticosteroids. There are other things that people are out there trying, such as platelet-rich plasma. I can tell you that it does not work as monotherapy. Having done a placebo-controlled trial. Fractional CO2 laser, again, does not work as monotherapy. Having done a sham-controlled study, it does not change the underlying inflammatory response. As standalone therapy, monolethal laser or other lasers are not appropriate monotherapy for lichen sclerosus. They may be adjuvant treatments with corticosteroids, but fractional CO2 lasers are not adequate monotherapy for lichen sclerosus. High-intensity focused ultrasound, or HIFU, has been studied mainly in China with some very good preliminary results. It has not been reproduced outside of China, however. Lichen sclerosus, one of the main symptoms of lichen sclerosus is sexual dysfunction. Dyspareunia is, again, the initial presenting complaint mainly in reproductive age women. Scarring of the vulva results in narrowing of the introitus, both anteriorly and posteriorly of the introitus, resulting in recurrent tearing and introidal dyspareunia. This is called vulvar granuloma fissuratum. Clitoral phimosis can cause anorgasmia, and surgical correction of this scarring can improve sexual function. Women with lichen sclerosus are less likely to have vaginal intercourse, oral sex, or masturbate than control groups. Women with lichen sclerosus are less sexually satisfied than women who don't have it, and they're actually much less sexually satisfied than women of chronic candidiasis. And yet, despite adequate medical treatment, women with lichen sclerosus continue to have significant sexual dysfunction as measured by the female sexual distress scale. So while we can improve sexual function, we don't normalize sexual function in women with the current therapies, such as the ultrapotent corticosteroids or surgery. And again, despite adequate medical management, a large percentage of women continue to have other dysfunction, persistent vulvar discomfort, and decreased quality of life. This is measured by the vulvar quality of life, or VULVO, I guess, because we're down under, the vulvar quality of life index, which was invented by a group of Australian fabulous vulval dermatologists, Drs. Warjaya, Lee, and Fisher in Sydney. And they've actually done a really nice series of articles on the effects of lichen sclerosus and quality of life and decreased quality of life. So let's move on to what this product, this device can be useful and how it may be useful. Oh, let's see, go back. For the management of lichen sclerosus. So this is this product is a non-hormonal and non-steroidal gel for the management of both atrophy and lichenoid dermatitis. It forms a barrier, a nice protective barrier on the skin to enhance hydration. This film, which dries as a film, acts as a functional epidermis. This improves fibroblast modulation, increasing collagen, as well as decreasing inflammatory cytokines, as well as regulating cell growth factors. So there's biological plausibility why this gel may act as either an adjuvant along with corticosteroids, or maybe as a therapy in itself for lichen sclerosus. So I've done 2 trials where I've finished one and I'm conducting a second one. And the first trial is very small. It's an open label trial, but only 5 women. But these women were biopsy proven out with active lichen sclerosus, and the only treatment was StrataMGT. So they were corticosteroid naive. So these were newly diagnosed women with lichen sclerosus. And it was an 8-week open label trial, and the primary endpoint was change in inflammation on biopsies between a pre and post-treatment biopsies. Additional endpoints were VQLI, the Vulvar Quality of Life Index, as well as Skindex 29, and CLISCO, which is another validated lichen sclerosus scale. And so, again, the preliminary results, and really I just finished these 5 women late last week, so we're really preliminary. I've actually been able to look only at the biopsies and my dermatopathologist of 4 of the 5 women. But 3 of the 5 women had reductions in symptoms on the VQLI, and 2 of the 4 participants had a reduction in inflammation on post-treatment biopsies. And again, this was not necessarily expected. We don't know if this would actually have more than just symptomatic relief, if this would actually have biologic efficacy. And if you look at a pre and post-treatment biopsy, here we have this biopsy, the pre-treatment biopsy, shows a very significant amount of lymphocytic infiltrate. So each one of these purple dots, if you are not used to looking at histology, each one of these is an inflammatory lymphocyte. It's a T lymphocyte, and they're all monoclonal, and they're all attacking ECM. And that's pre-treatment, and this is post-treatment. And you can see a huge reduction in the amount of inflammatory infiltrate between pre- and post-treatment biopsies. And again, these women were not getting any other treatment other than StrataMGT. I'm conducting currently a new study, which is a double-blind, placebo-controlled study of StrataMGT for the management of lichen sclerosus symptoms. So this is not as purely as a treatment for lichen sclerosus. It's really for the symptomatic control of women who have lichen sclerosus. And this is a double-blind, placebo-controlled trial of a 1-to-1 ratio, active to placebo. The participants are on a stable regimen of topical corticosteroids or a calcineurin inhibitor. They must be mild to moderately or greater symptomatic at the beginning, and they cannot use any topical estrogens or other emollients on the vulva. The endpoints are just these quality of life, the Vulvar Quality of Life Index, the Skindex 29, and CLISCO. Again, these are validated scales for lichen sclerosus. And we expect enrollment that has just commenced, and we expect enrollment to end by December of 2025. We have a data safety monitoring board which will evaluate after the first 50 women, and if we've not met statistical significance or if there's significant harm that any of these women have, we will stop the study. But we will go up to 100 women if necessary to show any statistical significance in this study. So again, this is preliminary data, but the data look good, and certainly we're very excited about this as an adjuvant treatment, at least for the symptoms of lichen sclerosus. Again, this is a QR code if you want to look at this presentation in more detail. And I'm happy to take questions at the end. Thank you very much.
Thank you, Dr. Goldstein. Our next speaker is Dr. Marc Winter. He's already behind me. He graduated from University of California at Irving College of Medicine, and he's the director nowadays of the Minimally Invasive Gynecology at the Hoag Women's Health Institute in the US. He's an international expert in robotic surgery with more than 20 years experience performing gynecological interventions. He's been also designated as the focused practice in minimally invasive gynecologic surgery by the American Board of Obstetrics and Gynecology. He was the first surgeon in the West Coast to perform a hysterectomy using robotic single-site incision technology, but obviously that was at the beginning. Nowadays, he's performed over 2,500 robotic surgical procedures. And then obviously his research interest is very focused on minimally invasive technologies, but also in hormone replacement therapy and menopause. And because of these last two, he's going to present preliminary data and some of the studies that he's been doing with StrataMGT. So yeah, welcome, and the stage is yours. Thank you.
Thank you, Eduardo. First of all, it's really an honor to be here speaking, so I want to thank IMS as well as Strat Pharma for having me present a little bit of the work that we're doing. I also want to thank Ellen Winter, my research coordinator, for her hard work and integral contribution to this study, without which would not be possible. So again, there's not a lot of time. I'm going to jump into this and move around relatively quickly. Wanted to talk about some of the stuff we're working on and where this fits in with other studies going on. So as we all know, GSM, or genital urinary symptoms of menopause, is very frequent. Over 50% of postmenopausal women will have symptoms. Actually, about 15% of women premenopausal will have similar symptoms. Vaginal dryness is the most common symptom, with over 90% of women having that to some degree. So why is it caused? Well, it's caused by estrogen deficiency, leading to a reduction in cellular substance. It can cause thinning of the epidermal and mucosal layers, resulting in decreased vascularity, decreased secretions, and it can also alter the vaginal microflora. What do we use now? Well, the gold standard now is estrogen, typically topical estrogen coming in different forms, creams, tablets, rings, pessaries. Good efficacy is seen. Drawbacks to it are potential side effects in women that have had, for instance, previous cancer, breast cancer, coronary vascular disease, or high risk of thromboembolic events. Also, I know with us, there's a segment of the population that would prefer, if the efficacy was the same, a non-hormonal mode of treatment, if that was possible. So in addition, things that have been tried, lubricants, moisturizers, vitamins really have not had significant clinical efficacy. Hyaluronic acid will have some efficacy, again, not the same as topical estrogen. So we had spoke, this is something I was interested in, and I heard about Dr. Hall over there, who's going to talk about his data and what he was working on in Australia, and I thought, wow, this is really exciting. This is something that I'd be very interested in. So we actually did a pilot study of our own, treating 9 women, and saw positive results. With respect to Dr. Hall's study, again, just briefly, he followed women with both GSM and lichen sclerosus for up to 2 years. And showed significant improvement in vulvovaginal conditions. So the study, which I will talk about in a little bit more detail, the VITAL-E study, is a non-inferiority study comparing novical silicone gel, which is the StrataMGT, versus topical estrogen. We picked a commonly used form of estradiol and estrase. There is also another study called the VALOR study, vaginal atrophy and long-term observational study, which is an unblinded study which will hopefully show results in several thousand. We're hoping 4,000 women eventually. So going back to the VITAL-E study, this is a single-center, randomized, assessor-blind, phase 4 study. We looked to determine efficacy and safety of the StrataMGT or silicone product in the management of genitourinary symptoms of menopause. There was a 1-to-1 randomization, which was randomized by a computer. There was an investigator assessment, and then treatment lasted 3 months, at which time there were online self-assessments monthly, and then at the end, an investigator assessment. Inclusion criteria included postmenopausal age and diagnosed GSM, and also having to have a computer and email. Exclusion criteria, anyone who was contraindicated for estrogen, for instance, women that had had breast cancer, we did not include in the study. So primary endpoint was patient-related vulvar disease quality of life index at the final assessment, which again was 3 months post-enrollment. We also looked at any safety endpoints, including adverse effects that would interrupt usage of the products. What we saw, as you can see on these curves, looking at clinical symptoms, is a strong trend towards benefit with both estrase, which is the curve on the left, and StrataMGT, which is the curves on the right. We looked at clinical signs. Again, we saw a benefit in clinical signs with both products, which were similar. It was interesting that there was a trend towards even greater benefit in the StrataMGT group. Again, we had relatively small numbers, 12 patients in one arm and 13 in the other. So again, we can't make any conclusions, but we can see a trend there. I can tell you anecdotally, we had a couple of patients with significant dyspareunia, with contracture of the posterior introitus, which were significantly improved both by assessor visualization and as well as by patients' reduction in dyspareunia. So there were a couple quotes I want to share with you from the StrataMGT group. I'm living my best life. Everyone should know about this. I noticed a benefit in lubrication and more pliability during entry of intercourse. I went from a 6.5 to a 4 in discomfort and improvement in dryness. I'm surprised at how well it worked. Also, with respect to performance, this was somewhat unexpected that there was a trend towards preference towards the StrataMGT group, and even with our small numbers, showed a significant difference in tolerability. So overall, StrataMGT showed a tendency for better patient satisfaction. Both treatments showed reduction in signs of symptoms. More patients obviously need to be recruited for this trial, and actually we have 2 new sites coming on board in the next 2 months. So we're confident we'll get our numbers up and have more to report. I was interesting, last night at dinner I met Dr. Goldstein and Dr. Hall for the first time, and I'm super excited about what we have here, because we all are seeing the same thing, seeing really good clinical results with this first pass, and very excited to see this through and where we go. Obviously, advancing genital symptoms of menopause treatment, we want to prioritize a durable non-hormonal therapy that effectively addresses both symptoms and tissue health while reducing long-term side effects. Thank you for your attention. We'll be happy to answer any questions at the end, or if anybody has questions, please grab me anytime during the conference. Thank you.
Thank you, Dr. Winter. Our next speaker is Dr. Phil Hall. He graduated from Monash University in Australia. He's the director of the St. Andrew's Pelvic Medicine Centre in Brisbane. He's a gynecologist and highly experienced surgeon with 35 years plus experience in the private and the public sector in Australia. His research interests are in fertility, endometriosis, pelvic pain, and urinary incontinency. He is specialized in a wide range of conditions involving the pelvis and persisting pain in the management of prolapse and urinary incontinence. He trained in the Monash University and is the director of St. Andrew's Pelvic Medicine Centre in Brisbane. So thank you very much, and the room is yours.
Thanks very much, Eduardo. It's great to be back in Melbourne. Obviously, I spent a lot of time in Victoria before I decided to move to the sunshine in Queensland. And sometimes you forget some of the things about Melbourne, and I experienced them yesterday as I got off the plane. It just rained and rained and rained. So I'd like to extend a welcome to our overseas visitors, and I hope you enjoy your time in Melbourne and at this meeting. What I'd like to talk about is the study that I have no disclosures, a study that I undertook at St Andrew's War Memorial Hospital in my private practice. And I seem to have got into this almost by default, because we all know how common lichen sclerosus is, how underdiagnosed, undertreated, and women suffer. So I ended up having StrataMGT presented to me as a potential new treatment. And sometimes out of desperation, you'll do things. And I thought, well, if I can help women with this really difficult thing, let's give it a go. So we got authorization for the study for 12 weeks. And we thought, well, okay, we'll see what happens. So this study was actually reported, and if you want to scan that QR code, it was reported in Women's Health Reports in April of this year. That's the contents of this talk. So we all know the impact in perimenopausal and menopausal and postmenopausal years of the sort of changes that Andrew was showing us, those dramatic changes of the vulva and the dysfunction, the pain, the discomfort, the burning with urination, the burning with defecation, and major sexual dysfunctions. So the common diseases that we see are lichen sclerosus and GSM. And we also run into another problem dealing with women because of our friends in the media who say that estrogens will give you cancer. And the last thing you want to do is have hormonal treatments, and the pharmacists tell us, well, only use that diprosone really, really sparingly because it'll do terrible things to your skin. So women are in this sort of dilemma of not of having symptoms but really not knowing how they can improve them, and hopefully something like StrataMGT, which is non-hormonal, non-steroidal, is going to be helpful. And frankly, I didn't know what was going to happen. So we set up the study with this gel as an alternative. It helps with hydration, reducing inflammation. We know it from the other studies with the silicone gel, it'll improve wound healing. And as Andrew pointed out, some of those things with the fibroblast regulation and also the genetics behind that. The agent itself is not absorbed, it sits on the skin, so again, it's unlikely, and we didn't have any side effects, and it's also an important alternative, so that we needed to explore where we were going with this. The study type was a single-arm, open-labelled control. We wanted to look at changes in the clinical signs and also the symptoms and see where we were going. Ethics approval was originally for 12 weeks, but we then extended that once we started seeing the early results to 2 years, and that's the data that's been published and we'll talk about today. So we ended up with 55 women being enrolled, and that was at the beginning. Now, I can tell you that after that 55 women and the success we've had, my practice has been inundated with people who want to come and see Dr. Hall with his magic gel. So we also allowed people to use concomitant steroids and any other treatment that they wanted to use. So this was an adjuvant. So the gel was actually applied minimum of twice a day, but often people in the early stages were using the gel after each time they voided to provide a covering for the skin and re-epithelializing the very, very irritated areas. So we plan to see the people at 6 weeks, 12 weeks, and further 6 months after that. Once we started seeing the results, we then extended our time. When we were writing the study, we weren't aware of the validated scores for vulval disease, so we actually made one up ourselves using 10 symptoms, using a 10-point Likert scale for clinical signs and also patient-reported outcomes. The demographics, the average age of women was menopausal, 58. Most of these patients had lichen sclerosus, because that's where we were targeting this, but they had concomitant GSM, and the responses to that were really quite amazing from their point of view, and also my point of view as the clinician offering a novel treatment. Now, this, at the IMS meeting in Brisbane in 1919, I presented the first part of that slide, and with this dramatic change over the first 6 to 7 weeks, with reduction in the symptoms that we looked at: pruritus, tenderness, swelling, dryness, burning with micturition, with urine hitting the raw skin, reduction in sex pain, stinging with defecation, and also irritation of clothes. The most significant thing that women reported was the improvement in sexual function and the lack of discomfort. The second half of this slide shows the continuation of improvement of symptoms and continuation of that improvement over the 2-year interval. And at the reporting stage, we felt that 17 women had complete resolution of all their symptoms. So these are the symptom improvement data, so that we're looking at significant improvements in tenderness, burning, dyspareunia, stinging with urine, and irritation with clothes. Clinical signs, and I was one observer So which I did actually get continuity of examining these same women. Dryness, tissue thinning, reduction in labial fusion, and changes in the labial resorption were all very significant. As you can see, each of those graphs shows significant reduction in the scores. So, the patient-reported outcomes of both the clinical signs and the visual pathology are really important. So that we're looking at greater than a 75% reduction in dyspareunia, with baseline scores going down from 6.8 to 1.69. The most important changes were in that first 6 to 7 weeks, and with that initial improvement, women were keen to then keep going with the treatment. And one of the things that really surprised me was our level of follow-up. We had 90% of women were still adherent with the treatment at 12 months. The only people we lost were those that actually moved away from Brisbane. And we even had one woman who wanted to stay in the trial, and we sent by post the follow-up tubes of StrataMGT to them. There were no reported adverse effects in any of these changes, apart from, and I don't know whether this is really an adverse effect, is staining of white underwear. So people then started using coloured underwear, and it became less a problem with laundry. So we've got really good patient feedback from our study. All the people we had in the trial had uncontrolled symptoms at the beginning. Most of them had had previous biopsies and were pretty unhappy about having another biopsy. And as Andrew pointed out, those biopsies may not have been overly helpful in any case. But what we really wanted to do is work out the clinical relieving of discomfort and improvement in quality of life for these women. One of the things that, as a clinician, that came over for me was the validation of the women's symptoms. They'd often been to see someone or other, gynecologist, dermatologist, whatever, ologist, and said, got lichen sclerosus, not a nice disease. Here's some steroids, and if it doesn't work, I can see you again if I really need to. So the validation of symptoms, the validation of disease process are really important in terms of the ability to adhere to the treatment and have symptoms acknowledged and taken really seriously. And part of my approach in all this was to organise the follow-up appointments to really say, I'm interested in your symptoms, I want to help you. Now, this is the brochure that we used at the time to recruit people, and we put this in the gynecology wards, the backs of toilet doors, because I thought to myself, where am I going to get these patients from? And these posters are still hanging around the hospital. And following on from this 2-year study, I've got cousins and aunts and daughters and grandmothers keep coming in, and they'll bring this poster or a copy of this poster on their phone and say, can I have some of your magic gel? So these are some of the comments. Because my response was so gratifying for these women, we've collected, a bit like Marc, these comments of life-changing. I used to pass out with pain with sex. There's no tears now, and tears and tears are spelt very similarly. And women were saying that they cannot believe what the treatment was doing for them when they'd had treatment in the past that hadn't worked. So in conclusion, we've got a promising new adjunct treatment for symptomatic improvement, and we hope that we will see histological improvement as we have more and more biopsies. This is a safe preparation. Women don't want to have estrogen-based therapy. They don't want steroid-based preparations because of the the media and the popular thinking. Rightly or wrongly, it still exists. So we've now got favourable outcomes with reported clinical signs and symptoms. And as in always, we need to have a larger controlled sample to confirm these results. And at St Andrews, we're now looking at starting a trial comparing StrataMGT with the available oestrogen preparation in this country, which is different from that available in the States. We will use not my own scale, but we'll use a validated scale, and we look forward to seeing what happens when we take our next trial, and we're hoping to recruit 100 women for this study. So, as Marc said, we're very happy to talk with you either after this meeting or anywhere around during the meeting. So thanks for listening to our conversation and looking at the results of our work.
Okay, so I will be presenting the data about the last study that we've been mentioning today. This is the content of my presentation, so I'll be talking a little bit about the product, how it came to fruition, the overview of the Valor study, and then the preliminary results since we are still recruiting, and then the next steps from here. So, StrataMGT, we've been mentioning it already since the start, but I would like to maybe summarize a little bit of what it is and why this type of technology makes sense in this indication. So first of all, we need to understand that this is a medical device. It doesn't have a pharmacological activity. It's a film-forming gel that is literally able to dry over any surface. And when I say any surface, it could be a wound, it could be mucosa, it could be healthy skin for that matter. So the key thing is that this film, once it's dry, it's going to stay there, and it will not be absorbed through the application sites. And because of that difference, or that way of working, that's why we have such a different outcome compared to other topical products that usually are designed to be absorbed. So as Andrew was pointing out in his slide, it is recreating the function of the epidermis by staying on the surface, okay? In general, we can summarize, well, there you go, that the product will help in mucosal healing. It will also be able to help in the healing of potential lesions or wounds in the mucosal tissue. It will also help with relieving symptoms, as we have seen in the studies that we have been discussing so far. But it's also going to help in the hydration, since the film, once it's on the surface, will regulate transepidermal water loss. By that fact as well, it will restore the barrier function, so it is a protective film as well. It is non-reactive. As you've seen, we have no reported adverse events in any of the studies. And as I said, the key benefit, the last one, is because it is not absorbable, that's how we get to the outcomes that we are discussing today. So StrataMGT lightly bonds to the superficial area. You cannot peel it off. Some people ask this question, which is fair enough. The product is over time through friction and obviously through bodily fluids. It's excreted, but it's not absorbed at any moment by the mucosa, and it will not be found systemically. So this environment underneath the film is the ideal environment for potential wound healing in case we do have a lesion. In case we do have a dysfunctional epidermis, it will help restore the function of that mucosa. Good, the application is relatively simple. So it's the product right now, it comes without an applicator, but it will be with an applicator as well. So it will be at the choice of the user. But yeah, so it can be applied intravaginally, but also, of course, in the outer part of the genitalia as well. So the recommended use at the moment is on a daily basis. However, we're also starting a study to see if we can actually reduce that frequency, because we believe that the effect may be sustained even longer than 24 hours. So that is a study that we are studying at the moment. The study that I'm going to discuss now, it's called VALOR. It's, as I said, actively recruiting, so the data that I'm showing here are preliminary as well, and hopefully by the time of the IMS 2026, I will be in the, well, not this podium, but in the podium in the next edition, showing you the data of 2,000 patients, what will be the first cutoff, and then we're hopefully going to increase this to 4,000. So we have enrolled so far 208, so it's around 10% of the first target. But yeah, so we're actually actively recruiting patients, but actively recruiting investigational sites as well. So if this is something of your interest, please come see me at the booth. So right now we are focusing on the US, and we have sites in California, Florida, Georgia, Nevada, North Carolina, South Carolina, and Texas. And then this is probably from a design perspective a much more simpler study compared to the ones we've been seeing so far. But the benefit of this one is the big amount of patients. So this is a simple survey that the patients can actually monitor most of the time themselves through their phones. I'll be showing you how it works. And obviously the advantage is the amount of patients. Okay? Yep. So the inclusion criteria is to have diagnosed vaginal atrophy, GSM, lichen sclerosus, simplex, chronicus, or planus. And then the patients will then be regrouped in their categories, and nothing major in the exclusion criteria that would be out of the norm. So the design of the study is, oh, there you go. So we see here a timeline. On the lower half of that axis, we see the assessments that happen on-site. So we have a baseline on-site assessment, then at 3 months, 6, 9, and 12 months. And then on the top side of that graph, we have the self-assessment that is done by the patient themselves through their phones. So as simple as that. So on-site assessments, we will focus on the investigator side of the outcomes of this study, and we will also look at validated scales, as we've been discussing before, like, for example, the VSQ, the VQLI, and other patient-reported outcomes. And then for the remote self-assessments, we will look at VSQ, VQLI, and other patient-reported outcomes. So, for example, itchiness or pain with a Likert scale. So from an outcome perspective, we're focusing on these 3 key areas. So we're definitely interested in looking at quality of life. That's why we are looking at different tools as well to measure this. But then obviously some of these scales don't necessarily look at particular symptoms that are very important for patients. As we were discussing before, pain during sexual intercourse is one of the most, let's say, worrisome symptoms for patients. So that's one that we will probably we're also separating and asking questions in particular around this indication as well. So this is a little overview of how the software looks in the background. This is how we manage the study. And then on the left side, you see an example of a notification that the patient receives on the phone. It's been a month since the last assessment. Please click here and take a few minutes to answer the questions. So it's a relatively simple study for patients to join, and so far it's been quite successful in the recruitment. So we're actually recruiting faster than what we thought, so it's actually quite a nice surprise to have. Good, so just on average, we're monitoring as well adherence to treatment. So we're checking how many times per day, how many times per week. And we see that the adherence is relatively high, or quite high, so which is usually an indicator that patients might be satisfied with the results that they're seeing themselves. But yeah, so that's something we monitor definitely as well. So as I said, what I'm showing now is not obviously the final data. This is preliminary, so we've only recruited 200 out of the 2,000. But anyway, we can already start seeing the confirmation of the graphs we've been seeing all this afternoon. So we see this tendency in the reduction of symptoms, or in this case, the VQLI index. For the majority of the patients, we only have 3 months data. There's only a few patients that have completed the 6 months, and then we don't really have patients that have finished the 1 year. It's a relatively new study, but at least I'm showing you the preliminary data so far. Same tendencies, we see them in, there you go, in symptom severity. As I said, these are the symptoms that we have taken out of the quality of life indexes, and then we're asking them independently. Itchiness, burning sensation, pain, irritation, dryness, and also dyspareunia, which has its own category. And this is the tendency which comes to confirm the graphs that we have been seeing so far. So we do have a quite significant starting point, and then so far it's being sustained as well over the 6 months period that we have data so far. With these few patients, we already have some statistical significances. So for example, in itchiness, burning, pain and irritation and dryness, it's already quite significant with 200 patients, but as I said, this is going to recruit up to 2,000, okay? This is the data for the other scale, the VSQ, which obviously has a different approach to ask quality of life questions, but the tendency is very similar as you have seen in the other slides. And then, as I said, dyspareunia analyzed separately and taken a special attention is also showing the same tendencies as with the other outcomes. And then showing a little bit of the clinical signs as well. This is my last slide. So we see on the left side of the column, obviously the baseline, and then over the period of 3 and 6 months, each of these clinical signs are also reported over the period of the study. Obviously, when we finish, we will also have a 4th column showing us the 12-month data. So obviously, we see that already with this few patients, we can see a quite promising results. And yeah, so this is my last slide. So thank you. And we will have now a few minutes to take some questions. So thank you very much for joining today, and thank you for your attention. Yes.
Hi, my name's Yen Chin. I'm from Bunbury in Western Australia. So I just want to know, is it available in Australia and the cost of it in Australia? Because I've just Googled it and it's about $69.95 US for a 1-ounce tube on your online store. And the second question that's related to it, is it the same as the StrataDerm gel which is used for scar treatment? And can that be used instead, or is it totally different?
Okay. First question, is it available in Australia? So the product is not yet available in Australia, so we are registering the product as we speak. We're expecting TGA approval within the next months. So this is our, and thank you for the second question. So we do manufacture other products, other devices. StrataDerm, which is the one that was mentioned, is our scar management gel that is available in Australia for quite some time. So this is our latest addition, and it's a fair question. Is it the same, and why couldn't we use one or the other? So what we do as a company is a technology, what I mentioned at the beginning. So it is a concept of film-forming gel devices. So, and then, as I said, this technology is able to dry and form a film over literally any surface. So that is the key innovation that we bring as a company to the market. But then taking that concept, we basically look at different indications and different physical needs for those indications, and then we develop sub-formulations. So in reality, the needs that you have in scar management are not the same as you do have in mucosal application, or for that matter, in chronic wounds as well. So for example, in scar management, you're looking for a formulation that is as robust as possible, so that you can only, or that you have to apply only once per day. When you're using these type of devices in mucosal tissue, The formulation is much thinner. It's easier to apply. It's less viscous, for that matter. And then we have differences in the physical properties, drying time, etc., of the gels. And then also important, maybe a bit more boring, but it's important to check out the regulatory aspect of this as well. So being medical devices, mucosal indication and/or body orifices as a category, the class within TGA, but also other regulatory authorities, is a higher risk device. So we couldn't use a product intended for scars in mucosal application or in open wounds. So it is two different formulas, but the reasons are mostly because of the physical characteristics. Thank you.
Hi, I'm Catherine Pratton from Sydney. So you did say that, or one of the presenters mentioned that it can be used alongside as an adjuvant to steroids. So can you comment on, if you're using it twice a day, how does it actually work that you're going to be using your steroids? And if you're not using it with steroids, what is the effect on cancer incidence? Do we know?
Yeah, so I will start the answer, but then I would like maybe Andrew to finish. In reality, we're obviously aware that steroids is the standard of care in the management of lichen lesions, and we're also aware that it is a precondition of potential future cancer. So until we don't have the definitive data to say that we are, as a standalone therapy, able to manage the pathology, then we do not want to make those bigger claims. So that's why we're being a bit more precautious at this moment of time. And that is the reason why we have involved Andrew and his expertise in lichen research. And then until we don't have that definitive answer, we would like to stay in the adjuvant category, but we're striving to get there, and eventually we will be able to show with the data that we are gathering at the moment that we could potentially be a steroid alternative for management of lichen. But as we do have only very early data at this moment of time, we would like to keep it in the adjuvant sector. And maybe Andrew, if you would like to add something.
Mainly ditto. Yeah, please don't use this when available as a standalone treatment until we have very good evidence that the inflammatory infiltrate has decreased as much as corticosteroids.
Can I just ask what the practical way of using it is going to be? If you have to put it on twice a day, how do you actually manage to get your steroids on and get it through the barrier?
Yeah, so I don't have a definitive answer. What we've been trying to do is to monitor the dependency to the steroid. So we're trying to look at a patient diary approach, as in, okay, so if using StrataMGT is enough to manage symptoms, how much can we reduce the use of steroids? But currently, maybe I'm going to defer the question as well to Andrew. What would you recommend if it is an adjuvant therapy?
I would apply the corticosteroid prior to the application of the Strata MGT, and ask the patient not to just. It's very important when the use of all corticosteroids that it actually gets absorbed. They can't just apply a layer of steroid and not rub it in. So just I guess it would emphasize the importance of rubbing in the steroid quite well, often after hydrating the skin with like a warm shower or a bath. To soften the epidermis, and then rub the steroid in for a minute before applying the StrataMGT.
Thank you.
Thank you.
If I could just put a comment in on that. What I found in my patients was that women often stopped using their steroid when they got the significant clinical effects of the StrataMGT, and they were using their steroids less and less.
My question is Claire Holberton from Canberra about the effect on the microbiome of the vagina and whether you had any data on that.
We have not, but we're actually interested in generating data in that direction as well. So, but unfortunately, no, we don't have data yet.
Hi, I'm Jackie. I'm an obs-gynae here in Melbourne. I just have a couple of questions, particularly worried about the vulval cancer risk with my LS patients. Firstly, do you have any longer-term studies slated, particularly to compare if there is that same risk reduction that we see with regular steroids in terms of whether you see that with the StrataMGT? But also the key thing about prescription medications is patients need to come back to have their prescriptions refilled, and then they get a clinical examination. And it's another opportunity for some health prevention and for a repeat examination. And what do you think about the way in which patients are likely to access StrataMGT? I'm assuming this is a non-prescription item, much like the scar adhesives, and how you think that might impact on ongoing care relationships?
Yeah, thank you for the question. So that will differ, obviously, from country to country. In Australia, we're assuming that the product will be an over-the-counter device, but who knows? Over the time, we may be looking into some type of reimbursement if the data is strong enough. This is something we are doing with some of our other products, but it's likely that it will start like this. And yes, I definitely agree with you from a design perspective. How does it affect if we are comparing with products that need prescription? And obviously that prescription may affect the design of the study. But yes, this is something we take into consideration. And yeah, so as I said, the product will likely be over the counter as a starting point in Australia. Was there, I'm not sure if you had more questions at the beginning? Or?
Yes, the other question is about longer term studies, particularly to see if the risk of vulval cancer is the same as untreated women or reduced similar to those that are on regular steroid maintenance therapy.
Yeah, so we don't have that in our designs yet, but it's certainly a good point. So in the study that we're doing in Lichen at the moment with Dr. Goldstein, so we're not looking at the reduction of risk of potential cancer at the future, but I do agree with you that may be something we would want to add in our portfolio of studies. So, but we don't have it at the moment.
We are monitoring women in the study with vulvoscopy before enrollment and after enrollment throughout the study. So we're monitoring for any progression to VIN or obviously vulvar cancer. But again, the large study is as an adjuvant to clobetasol on a stable regimen, which, as I'm sure you're aware, is the only thing that has been shown to reduce the risk of vulvar cancer. And again, as a treatment, this is a very, 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 very preliminary data of a 2-month treatment. So clearly, we have no evidence whatsoever that it lowers the risk of vulvar cancer, and none of us are saying that it does, and we're not making that claim, and it would require an enormous amount of work to make that claim. So none of us are saying it. And let's be clear, this right now would be only an adjuvant to the standard of care, which is optimal treatment with corticosteroids, as shown by Drs. Fishers and other fabulous Australian dermatologists, as the only way to lower vulvar cancer.
Yeah. Appreciate that clarification, because I think that's really key.
Thank you.
I suppose a comment I'd like to add to that is often this is not just the, I'll phrase it another way. These are postmenopausal women who are offering to have systemic replacement hormone therapy as well. So it's a matter of them coming along for their further prescriptions for that, and at the same time you can check their vulva.
Wendy Vanslow from Melbourne. I just wanted to ask whether interaction with silicone vaginal dilators or sex toys, as silicone lubricants do, if there's a problem.
Yeah, so we've done some studies with the combination or the interaction with these type of other products, and for the moment we are being precautious, and then we're asking patients to use other types of prophylactic measures. But yeah, so at the moment, we do recommend to not combine with for example, spermicides or things like this. So yeah, in the instructions for use, we are rather conservative in that approach. Yeah, thank you. I believe there's, yeah.
Sue Downey, University of Melbourne researcher. Is there anything to suggest that this will have to be applied long-term, as in forever? Because is it actually changing the cells or just providing a protective layer? And secondly, is there a difference between women with VVA and lichen sclerosus in terms of the cells? And again, is that going to be a long-term requirement for both categories?
Yeah. So, good question as well. In reality, or from a design perspective of this product, so we were trying to bring a concept that is safe and could be used long-term. So to answer the question, yes, it is intended to be used long-term. The data that we've been showing today is up to 2 years. We don't really have more beyond that. But yes, it is intended to be used on a daily basis since it is as safe as it can get. Or so far, we have not reported any adverse events. So will it change the cells to a level that it's no longer required? Well, so far, unfortunately, it's a wishful thinking for us as well, but we don't really know. So far with the data we have, we can only make the claim that with daily application up to 2 years, we're able to sustain the quality of life of these patients. But then we do not have, for example, the biopsy data at 2 years' time. So this is only something we've started now, looking at biopsies as well, but we have not done it in the long-term studies. So unfortunately, the data is what we have. So, but thank you. Yeah.
I just wanted to, Julie Cohen from Melbourne. Have you been able to use this for aphthous ulcers at all?
So not this formulation, but we do have other products in wound care, and then our data is quite interesting. So maybe it's not for this this bigger audience, but maybe that's something we can discuss at the booth if you like. So we do have other products that are maybe better indicated in wound care, ulcers, etc. But yeah, so with this particular formulation, we do not have that data.
I sort of was meaning really specifically vulval aphthous
It
ulcers.
may be great for vulvar apthi. It actually, it's a great idea. You know, obviously, you know, recurrent aphthosis, Behçet's, you know, just Lipschitz ulcers. Absolutely, probably amazing. Just again, as a barrier, as these ulcers here heal, because they can be incredibly painful, as you're aware, I'm sure. Great idea.
Thank you.
Hi, this sort of comes as part of that question. Can you comment on its use in lichen planus?
So we've only recruited a few, if I'm not mistaken, Dr. Hall, in the study. We had a few with lichen planus, but it was not a big proportion. I cannot really remember, but the majority were lichen sclerosus. Right. We had a few of lichen planus, but I wouldn't be able to say that it was a big group enough to make a separate analysis. So we recruited a few, but we don't really have big data on lichen planus yet. Yeah. Okay. Well, thank you very much. It was a pleasure being here, and thank you for your attention. Yes.